sorry about that, about enrolling representative populations, specifically disadvantaged and historically underrepresented groups. I have no disclosures. So I'd like to give you an overview of what the next 30 minutes is going to cover. I'll begin with a description of the traditionally challenging populations, some historical background, and practical applications for you as clinical investigators, and close with some special considerations. So who are the challenging populations? In general, racial and ethnic minorities and women study participants have been historically underrepresented in phase 3 clinical trials. And if you included cancer clinical trials, the list would include persons that are over the age of 65, adolescents, as well as persons living in rural communities. Persons from economically disadvantaged backgrounds can also be challenging to recruit and retain in clinical trials. The lower socioeconomic status often means limited access to educational, social, and financial resources. This limited access to resources often translates into these potential study participants having difficulty understanding consent forms, being at higher risk for loss of follow-up due to transportation issues, frequent changes in their telephone access, as well as instability in their housing. Why is it important that these groups are adequately represented in your study sample? One commonly cited ethical argument for having adequate representation in clinical trials is related to distributive justice. This means that the benefits and the risks of participating in research should be evenly distributed throughout the population. For example, prior research has shown that there's a disparity in minorities participating in phase 1 clinical trials in comparison to their participation in phase 3 clinical trials. Also, a representative study sample allows for the results to be applied in a more generalizable way to the entire population. Last year, myself as well as Dr. Johnston, some members of the Neurological Emergency Treatment Trials Network, we attended a Trans-NIH Workshop on enrollment and retention of participants in NIH-funded clinical trials. This demonstrated to me that this continues to be a top health priority as well as a policy issue, specifically as it relates to social policy. NIH trials are publicly funded trials and don't often have adequate representation for minorities, women, and economically disadvantaged populations. This meeting brought together research and researchers in an attempt to try to distill down which strategies have been successful in ensuring that you meet your recruitment goals. So next, I'd like to highlight some aspects of U.S. history that are thought to play a role in why we continue to see these recruitment challenges today. So this is an example of an ad that targeted African American males for a study that would provide free blood tests and treatment. The Tuskegee study of untreated syphilis in the Negro male was a 40-year experiment conducted by U.S. researchers from the Public Health Service working with Tuskegee Institute, a historically black institution, on the natural history of syphilis. Interestingly, this study originally was proposed to examine a hypothesis that syphilis was somehow different in black males, and then, therefore, if this study demonstrated that there was a difference, then that would be a reason to provide treatment to black males. According to the CDC, this study was initially projected to last for 6 months, but it continued from 1932 to 1972. The infected men were monitored for progression of the disease, and when penicillin became the gold standard in 1947, this was not offered to the men. So the issue with this study, which I'm sure many of you are familiar with, but it's deception. So the men were recruited into the study and led to believe that they were going to get treatment for bad blood, and they didn't receive any. So similarly, the U.S. Public Health Service conducted a syphilis experiment in Guatemala from 1946 to 1948, where doctors infected soldiers by using infected prostitutes, directly infected 700 prisoners, and mental health patients with syphilis and other sexually transmitted infections. But unlike the Tuskegee study, the subjects here were provided with penicillin because the objective of this study was to actually test the effectiveness of penicillin in treating and preventing syphilis. This is an example of where vulnerable populations that were in prison or had mental health problems, they were engaged in a clinical trial without proper informed consent. And this study reportedly resulted in 83 deaths. Another important but maybe less well-known example is Henrietta Lacks. There was a book that was published in regards to her in the last several years. She was an African-American woman in her 30s who went to Johns Hopkins for care. She was evaluated by Dr. Gay, and at that time she had a pap smear performed and had cervical cells removed. She subsequently died of cervical cancer. However, at that time in history, scientists had not been able to replicate cells successfully, and Henrietta's cervical cells were noted to replicate within 24 hours. And this became known as the first immortal human cells grown in a laboratory. Since 1951, these HeLa cells have played an integral role in scientific discovery and have been replicated millions, if not billions of times. They've been used in experimental testing for polio vaccines, chemotherapy, gene mapping, and cloning. The cells can be found around the world in cell culture labs and have been used to develop therapies for herpes, leukemia, influenza, Parkinson's disease, and the list goes on. However, these cells were taken from her cervix, reportedly replicated without her or her family's permission, and profited off of without any compensation to her remaining family. I found a New York Times article that highlighted that the scientists also began experimenting on Henrietta's children in order to try to learn more about Henrietta cells, but the children were not aware that they were being experimented on. So I show you these three historical examples because each of them have helped to redefine how researchers interact with research participants, particularly increasing the transparency of informed consent process. But these stories also have a lasting legacy on the public's perception of research and researchers, particularly in the minority and the disadvantaged communities. Because unfortunately, these examples are real and not urban legends. During the Trans-NIH Workshop that I mentioned, they discussed a population poll conducted in May of 2013 by Research America, a nonprofit organization, where they explored lack of trust as a barrier to participation in clinical trials. They stated that fewer than 10% of Americans participate in clinical trials and asked, which of the following do you think is the reason that individuals don't participate? As you can see, for each racial and ethnic category, greater than 50% of each group polled reported a lack of trust as the primary reason. Mistrust is real for many people, partly because of stories like the ones I highlighted previously. In a prior study of African American patients and their reasons for participating in stroke prevention trials, one of the common reasons for not enrolling was fear of being a guinea pig. These historical examples highlight mistrust, but that's one of several factors that contribute to difficulties in recruiting racial and ethnic minorities. Recognizing that lack of participation in clinical trials by racial and ethnic minorities, as well as women, limited application of research findings, this led to a series of reports that were done in the mid to late 80s. Eventually, the National Institute of Health created the NIH Revitalization Act of 1993 as a way to improve racial and ethnic and gender makeup of clinical trial study samples. There were two main objectives: inclusion, specifically outlining the importance of appropriate representation of women and racial and ethnic minorities in clinical trials. It also emphasized the importance of reporting outcomes by race, ethnicity, and gender. One of my colleagues that you will meet tomorrow, if you haven't met him yesterday, James Burke, or Jim Burke, he actually did a review of minority enrollment in NINDS phase 3 clinical trials that spanned from 1985 to 2008. He found that African American race-specific data was present in approximately 3/4 of the trials. However, less than 1/4 of these trials reported Hispanic ethnicity. So this makes it hard to draw conclusions about representativeness if the data is just not available. These guidelines were created to ensure that NIH-funded clinical research, particularly phase 3 clinical trials, empirically tested for differential responses. These guidelines stipulated that clinical research must be conducted in a manner that sufficiently allows for testing among diverse sexes and racial and ethnic groups. It applies to all grants and cooperative agreements and clinical research, which is defined as patient-oriented research, which includes research conducted on human subjects or material of human origin, for which an investigator directly interacts with human subjects. Specifically, mechanisms of human disease, therapeutic interventions, clinical trials, new technology, epidemiologic and behavioral studies, as well as outcomes and health services research. So basically everything involving human subjects, typically this mandate applies, except for in vitro studies where human tissues can't be linked to living individuals. In 2000 and 2001, based on feedback from clinical investigators, there were revisions made to the NIH policy in an attempt to better clarify the guidelines and NIH expectations. So when does it not apply? These inclusion guidelines do not apply if there is clear and compelling evidence that establishes to the satisfaction of the relevant institute or center director that inclusion is inappropriate with respect to the health of the subject or the purpose of the research. So for example, in a case if you were studying cystic fibrosis, maybe in that case you wouldn't be expected to have adequate minority representation just because the disease process is not prevalent in that group, and other groups like minority groups. Next, I'd like to try to transition to talking about practical applications of these guidelines. So what's considered appropriate? It really depends on what your research question is. First step, you have to decide whether you expect that there will be clinically important differences by race or ethnicity, or you can include gender depending on what your question is. And if you're unsure, there are other factors to consider in determining who needs to be included in your study sample. So what is the state of the existing knowledge? Does data already exist that suggests that there's differences that exist by race? For example, prior research has already demonstrated that African Americans tend to have worse disability after a stroke when compared to whites. Therefore, if you propose an intervention to reduce long-term disability after a stroke, it will be important to ensure that you have enough African Americans in your study sample to test whether there's differences in disability by race. On the other hand, maybe your study is more hypothesis generating. For example, for myself as an emergency researcher, I am interested more so on the process of enrolling patients in clinical trials in the emergency department, because I recognize that the environment is very chaotic. We don't know these patients. We have no established relationship with them. Their primary doctors don't know us. And so we are presenting opportunities for them to be enrolled in trials that may be confusing to them. They may not understand as well in this type of environment. And particularly given the history in our country, this may disproportionately affect minorities and patients of lower socioeconomic status, where when they're presented with a research opportunity in this environment, they may be less trusting and more likely to decline. And so if I were to design a study that examined the enrollment process, I would have to be sure that I had enough representation from African Americans to examine whether there's racial differences there. The other thing to consider is your study design. So say that it's clear that there are obvious differences by race. However, you are hoping to explore, well, what explains these differences? So you know that you have to have adequate representation, but you may have to oversample and include higher numbers in your study sample if you're going to also examine additional predictors. Some would consider how much of the minority population is affected by the condition, which is typically referred to as the disease burden. And so populations that have higher likelihood of the disease should be well or overly represented in the research trials, as they would be the ones that would likely receive the greatest benefit from scientific advances related to that disease. So next I'll highlight 2 study sample approaches to consider when thinking about how best to justify your recruitment goals. So So disease rates is one approach. This strategy aims for the proportion of the minorities in the study sample to reflect the relative proportion of the disease in the general population. So in another example related to trials on traumatic brain injury, in one study, like a multi-site study, they ended up trying to gauge whether they were disproportionately enrolling minority participants. And so they had a registry for the state that they were able to look at the overall rate across the state of the number of people that sustained a traumatic brain injury. And then they compared that to the number of people that they actually enrolled in their trial. And so that's a way of having a sense of what is the epidemiology of that state and how does that reflect the proportion of people that you would expect in the different minority groups that you should be able to enroll in your trial with that same disease state. The other method you can use is based on the census population rates. So if there's no difference in the racial and ethnic prevalence or outcome of a specific condition that you're studying, then it would make sense that the proportion of minorities that you enroll in your trial should just reflect the proportion of minorities that are in the country, rather than having to increase the number for that particular study. So after deciding on your study design and target sample, there are other factors that are associated with willingness to participate in research and achieving a representative sample, which relate to the participant, the research staff, and the study design. Prior research has shown that beyond concerns about mistrust, there are other participant factors that decrease willingness to participate in research, such as literacy and numeracy, prior experiences with healthcare and health providers, because those prior interactions are going to affect how they're going to perceive you and their willingness to trust you. Transportation issues, mobility of the patient, family opinions, financial concerns, and lack of awareness. Prior research has also examined whether characteristics of the principal investigators or the research staff are associated with meeting recruitment goals. Investigators have found evidence that minority patients report an increased willingness to participate in research when the research coordinator or the recruiting person is of the same race as them. In a survey of over 300 investigators, greater success with meeting minority enrollment targets was associated with prior dedicated minority recruitment training, the use of a diverse range of active recruitment strategies. So instead of just sending out flyers or maybe potentially putting an ad in a paper, when people engage in things that really get them face-to-face with the community, or when they have partnerships with community-based organizations or develop culturally tailored material, they had higher success with meeting their recruitment goals, as well as when the investigators themselves had a specific interest in racial and ethnic differences in their research. Some investigators have found that health providers can also be a barrier, particularly when they function as gatekeepers. In this role, they may be reluctant to approach or refer a racial or ethnic minority or woman or someone from a socially disadvantaged background, or refer them for specific study opportunities because they may have the assumption that, oh, they probably won't participate, so I'm not going to approach them. Or they may feel like, oh, they may not understand the consent form, I don't want them to get harmed, and therefore I'm not going to tell them about it. However, this paternalistic approach is problematic because it decreases the potential participants' awareness of research opportunities, and it also doesn't demonstrate respect for the patient and their own decision-making. Lastly, the study design itself can be a barrier to representative enrollment. With complex study designs, as well as even straightforward study designs, the consent process can be challenging to understand. Prior research has shown that difficulties understanding the study and what's expected can lead to confusion, mistrust, frustration, and result in declining and potential participants declining to enroll in a trial. Also, the study design, particularly those that require interventions, may have multiple assessments, follow-up visits, laboratory and diagnostic tests, and this also requires multiple visits to either the hospital or the clinical setting, which can be particularly challenging for patients that have mobility issues or transportation issues, as well as other competing demands. So, if they have to take time off of work or arrange childcare, they may be less interested in participating in a trial that seems burdensome. So last year, some of the feedback that I received is that a lot of people wanted more information about recruitment strategies. So for the next section, it's going to focus on recruitment strategies to help overcome some of these barriers. There are investigators, Brown et al., that developed a conceptual model for recruiting diverse women in research studies, which could be a helpful framework, hopefully, for you as you approach recruiting other challenging study populations. So their work was based on a literature review, focus groups with study participants, surveys of potential participants in the community, interviews with community leaders and investigators that were involved in the study. And they determined that recruitment interventions should target these areas: awareness, acceptance, and access. They defined awareness as the participant having an understanding of the importance of research, the operational process, and the value of participation. This can be enhanced through outreach presentations to the community and the quality of the educational materials. Educating the participant on the value of research can be influenced by understanding what motivates the participant. So, for example, research shows that for elderly populations, they are more likely to be motivated if they know that there's going to be societal benefit. At that stage in their life, they're like, if it does good to the community, they would be interested in participating in it. Some other people are motivated by personal benefit, so sometimes the monetary incentive is going to be what leads that patient to participate. But getting an understanding of what the individual value and incorporating that into your study design can help to overcome these barriers. So it's important for that recruiter, that person that's face-to-face with that potential participant, to be effective in communicating the specifics of the study, addressing the patient's concerns, and being able to talk confidently about the potential benefits of participation. Acceptability is defined as the influence of the broader community to support participation in the research trial. Therefore, a participant may be influenced by the perception of approval or disapproval of enrolling in the trial, depending on who the person is and the community that they identify with. For example, within this study, they found that women that were from a higher socioeconomic status felt like they were educated about the value of research. Therefore, if they did not participate, they weren't doing their duty because they knew how important research was. So depending on which population you're engaging with, sometimes getting a sense of what they value can help in engaging them in the research trial. So the author suggests using social marketing as a method to increase consumer knowledge as well as acceptability, which requires that you get to know your target population and develop a sense of what sparks interest in them as well as what they value as a group. Outreach workers, again, can be utilized to connect face-to-face with the community and explore individual attitudes and provide education about the research study. It's also important to engage stakeholders as a way to increase social acceptability. This could be with community leaders or endorsements with a respected elected official, if you could find one. So access focuses on research teams facilitating better access to the clinical trial itself. So thinking about the pragmatic barriers that the participant will face, and then developing a strategy to address them. So providing transportation, or in another study, and I think at University of Michigan, they also have mobile units that are available that will go to the patient rather than having the patient come to you. Or they'll set up the mobile unit to do testing within the community rather than having the patient come all the way to the institution itself. So these have been strategies that have been implemented in other trials to help increase participation as well as address retention issues. Participants may also have some competing obligations such as child or elder care, and this is particularly true for women because of their social responsibilities, and unfortunately that's going to limit their availability. Therefore, providing caretaking services can make participating in a clinical trial less burdensome. Providing mobile phones or at least minutes can also aid in maintaining contact with your participants, as it's common for persons from lower socioeconomic status to have variable and inconsistent phone access. Adapting consent forms to align with the preferred language and or the literacy level can enhance transparency and understanding of the trial itself and reduce confusion for potential study participants. So I want to just share quickly kind of like a case study that highlights a strategic approach that the investigators of the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study used. So this study sample targeted minorities and socially disadvantaged, specifically African Americans and whites 30 to 64 years of age in the Baltimore area. And their objective was to assess differential effects of race and socioeconomic status on incidence of disease, health risk, morbidity, mortality, and their study was a longitudinal study over a 20-year period. They identified participant, community, and research team barriers based on literature reviews as well as meeting with stakeholders within the community. The specified barriers were similar to those that I referred to earlier: mistrust, economic and time constraints, disease burden, personal biases, and then they developed strategies to address each barrier. But for the sake of time, I'm just going to highlight one from each category. So the study team recognized that economic and time constraints can limit participation. Therefore, in addition to monetary incentives, the investigators adopted evening and weekend scheduling times for examinations to provide more flexible options to accommodate the study population. To address community concerns about exploitation, beyond just adhering to the good clinical practice guidelines and IRB recommendations, the investigators really tried to attempt to increase transparency in their consent forms and educational materials by using the Flesch-Kincaid readability scale as a way to gauge whether what they were aiming for and the understandability of the consent forms, whether it met the needs of the population. As well as they presented video options to ensure that they had multimodal material available to the community to ensure that they understood the intent of the project. Lastly, they targeted researchers and staff, recognizing that we all have personal biases, and they created a cultural proficiency educational module to stimulate self-reflection, to discuss really difficult topics like ethnocentrism, prejudice, as well as stereotyping. And then along with that, it wasn't just about bringing up these sort of difficult topics, it was really trying to give them practical strategies of how to avoid cultural generalizations as well as demonstrate sensitivity and respect. So for example, if it required them to go door to door to check on the participants or recruit participants, they told them that after their interaction, if the participant is not sure whether they want to participate in the trial, instead of telling them, well, I'll come back next week and I'll follow up with you, they made a point to tell them, avoid that, and instead make sure you ask for permission to return to their house. That way it demonstrates to them that we want to make sure that it's okay for us to return. When is a good time for us to return so that they have a role in this process? And so they were really trying to address these sort of difficult connections that sometimes investigators will have with the surrounding communities, particularly with lower socioeconomic status persons as well as minority populations. And I also provided to you, I don't know if anyone has had a chance to skim it or to read it, but some supplemental material by Ubeco et al. That really tried to summarize what do we know about recruitment interventions at this point. And the gist of that article, if you haven't had a chance to read it, is that the data related to recruitment interventions is still very limited. And a lot of times, interventions are going to be strongly encouraged because it seems like it's the right thing to do. It seems like connecting with the community is the best way to get people involved and interested in your work. But unfortunately, a lot of the data is not adequate to draw generalizable conclusions. And so the time involved to do outreach, the cost that's involved, the specific components that were utilized, a lot of that is not documented in the literature. So it's hard to apply it to different populations. And because often it's not empirically tested, a lot of the interventions are just applied broadly to everyone that's enrolled in the trial, and there's no control group that didn't get the recruitment intervention. So it's hard to gauge which groups it's effective for and when. So lastly, I'm just going to conclude with some special considerations. The other thing to consider related to some of the potential stroke research that you may do or research on traumatic brain injuries is exception from informed consent. Exception from informed consent is of particular importance in research involving patients where prospective informed consent is not feasible. This process is used when you're testing therapeutic interventions that are time sensitive, such as epilepsy or traumatic brain injury or cardiac arrest. And in order for you to conduct these EPIC trials, it requires community consultation, and you should be aware that there may be fear associated with this type of study design in the general population because it doesn't use traditional perspective-informed consent processes. This fear may be of particular concern among potential socially and economically vulnerable populations or institutions that serve these populations. So this is an example of an article just last year in Seattle Times which highlights one of the trials, and it just shows that there's persistent wariness among lay people in regards to EPIC research. This is a local example from the Detroit Free Press where in 2007 they were concerned that for this particular trial that there could be disproportionate higher enrollment among minorities. And then this is an example from the San Diego area where this area that's south of I-8 is a predominantly poor and minority community, and they were raising concerns similar, bringing the term bad blood up there. It's kind of bringing this sort of historical fear. Are we potentially targeting a vulnerable population unfairly? So the take-home point, the increasing clinical trial participation requires connecting with the population through improved acceptability, really building trust and creating more patient-centric opportunities to facilitate clinical trial participation. So moving forward, it will be important to incorporate innovative recruitment strategies to reduce these barriers and increase awareness about the importance of participating in clinical trials. However, these recruitment strategies must also be rigorously documented and tested to better gauge what's effective, what's the time commitment, and what's the cost involved.
Thank you. That's great. Questions?
Yes.
You mentioned when you were talking about exploitation or community education, I think about a consent form, and one of the studies had a particularly, I think you mentioned a name of a guideline for consent form.
It is the Fleisch-Kincaid readability scale.
And what does that do exactly for in the consent form?
So I believe it tries to reflect what the readability of the consent form is. So the exact process that's involved, I would probably have to look it up and get back to you. But it was a way for those investigators to ensure that the consent form is actually understandable based on what they expected that the community would be able to understand.
Thank you for your talk. One thing that I think we often hear back from different kinds of groups are that you come with a question, you've done your research, and then you never hear anything more. And I'm wondering if you have suggestions about communicating study results, positive or negative, or ways of engaging with the people who have participated or the community that you've involved after the study is over.
So I know for example, EPIC studies, there is this public disclosure component of the regulation where the expectation is that you either publish the study in a journal or you potentially could post it on there's a docket review website that's available. And so I think there is a lot of flexibility in regards to how you can do it. There's straightforward ways that are expected in the academic environment where it could be an article versus just sort of putting the paper online for people to review if they want it. But I think because there's no strict guidelines, you could honestly do whatever you wanted. And so, for example, there's a study that I'm working on with some of my colleagues here where we were thinking of doing something within the community because it's a study, this is a health services research project, but it's asking the community about the impact of healthcare reform here in Michigan. And so we're interviewing a lot of the people that are enrolled in the new insurance coverage that's available, but part of us ensuring that they learn as well from the information that we gather from them, we're thinking about creative ways to actually go into the community to disseminate the information afterwards. And the primary investigator was open to doing it in a more public forum, potentially using video or photographs to really show this is what health insurance meant to you in Michigan. So I think there's a broad or a variety of ways that you could potentially do it. I think in academics, it feels easier to just put it in a journal, but we know that we don't always read those journals. So I think when you want to engage lay people, you may have to develop creative strategies within the community to really get this information back to them. Yes?
I do stroke, and I'm just wondering, I'm just in the context of enrolling patients in acute trials where there's no waiver of consent and it's a stressful situation and they're receiving a lot of new information at once. Do you have any strategies that you use in your environment, or does anyone else to maximize enrollment?
So that's partly why I'm interested in that topic, because specifically for acute care research, there's nothing out there. The closest that overlaps with the acute care environment is cancer. So they've seen from looking at videos of the process of sort of sitting down with the patient, giving them information about the trial. They reviewed the videos to see between African Americans and non-African Americans whether they asked questions, and they found, at least in that scenario for that particular investigator, that African Americans were less likely to ask questions. And what that means exactly, no one knows. I mean, because it doesn't necessarily mean that they don't understand, but it seems like they were less engaged. So the bulk of the data more so focuses on cancer research, and whether that can be actually applied to the acute care setting is unclear, but that's why I think that it's important in this area to really explore in this sort of nuanced environment what strategies work well and what strategies don't. I know I talked to some people in New York at NYU, and they are focused on stroke research, and they are focused more so on the recruiter. And really trying to use like motivational techniques to interact with the patients and seeing what effect that has on whether the patient enrolls or not.
Can you expand on motivational techniques?
So this is an early conversation that we're having with them. So we're supposed to have a follow-up meeting. The person that does the research primarily, that's what she's done for the last 20 years. So this is something that's new to me. But because I'm interested in acute care research, we are just talking to see is there a way that we can apply it potentially to one of the neurological emergency treatment trials.